The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Kashlak Memorial Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders. I'm Dr. Matthew Watto, here with my great friend, Dr. Paul Nelson Williams. Tonight, we're going to be talking about delirium with a fantastic guest, Dr. Esther Oh. Paul, how are you doing tonight?
I'm great, Matt. Thank you for asking. How are you?
Good. You know, it's the night before Thanksgiving, not when they're hearing this, but, in real time. Let's let the audience know what's up. And
sure, peek behind the curtain.
What else would we be doing, Paul, but recording a podcast? And I am so glad we did, because this was a really fantastic episode. And I got to hang out with you, my bud.
Yeah, right. This is like the old days on Thanksgiving Eve. Exactly like my college days.
All right, Paul, let's tell the audience what is it we do on the show, and then introduce our co-host, and we'll get the guest's bio.
Yeah, thank you. I was trying to think of a way to seamlessly transition into that and just failed. So thank you. Strong work there. We are the internal medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. As you mentioned, we are also joined tonight by our producer, and as I believe we describe him, hospitalist whiz kid, Dr. Adam Barelski, who I will first say hello to. Hello, Adam.
Oh, hello, Paul. Hello, Matt.
Surprised you with that one.
Yeah.
And I will now let you tell us about who we talked to and maybe even a little bit about what we talked about.
Of course. We had an amazing conversation tonight with our guest, Dr. Esther Oh, who is an MD, PhD, and the Sarah Miller Colson Human Aging Project Scholar, and an associate professor in the Division of Geriatric Medicine at the Johns Hopkins University School of Medicine. She is also the co-director of the Johns Hopkins Memory and Alzheimer's Treatment Center, and currently she serves as the president for the American Delirium Society. Tonight we had a wide-ranging review of delirium. We talked about how to recognize delirium. We spent a long time talking about prevention strategies, which I think is really important. We talked about hypoactive and hyperactive delirium, and we got into the thorny question of when and when not to use antipsychotics.
And before we get to it, a reminder to the audience that this and most episodes are available for CME through VCU Health at curbsiders.vcuhealth.org. Well, Esther, you're really being indoctrinated into the whole podcast culture here. We all just clapped together for some reason, and now we should bring the audience in. So can you tell them a little bit about yourself, like a one-liner, and be sure to throw in a hobby or interest that you have outside of medicine?
Sure. I'm an internal medicine physician with subspecial training in geriatrics. I would say I have rediscovered the joy of post-COVID-19 travel with my family.
Hallelujah.
And what is the most recent destination that you've been to?
Well, Italy, and then we were also in Greece.
Oh, amazing.
Yes. Highly recommended.
I think I will do that.
Yeah.
I always like to ask, I've actually almost run out of pop culture to consume. Well, it doesn't even have to be pop culture, but just culture in general. So I'm always curious for our guests if there's a book or movie or show or some music that you listened to recently that you enjoyed that you would recommend to our listeners.
Yes. I'm actually, Paul, I'm an avid reader, so I have actually several, if that's okay, because I just really love reading books, and I'm going to tell the listeners how I do it. So one of probably the best books I've read recently is The Emperor of All Maladies by Dr. Siddhartha Mukherjee, and also Healing by Dr. Thomas Insel, and Creative Confidence by the Kelly brothers, who started the Stanford D School. But one article that I would really love for your listeners to read it's something called Who's Got the Monkey? And it's about management time. And it's published by Harvard Business Review. That was published in 1974. It's one of their best-selling reprints. It's going to change your life.
Great title. So I mean, I'm very intrigued.
I love that article. And I think it was a book after that too.
I'm not sure, yeah, but yes, I have given it to several of my colleagues, all of my mentees. Very, very good article.
tell us about some of the best advice that you've gotten throughout your career, or something that along with your training that you've picked up that you tell some of your mentees or some of the people that you teach.
Yes. So one doctor that I remember is someone who I met when I was a third year medical student, and he said, when you see someone with an acute mental status change in the hospital, the first thing you should think is, what did the doctor do? And I've never forgotten it. And that's what we're going to talk about today.
Paul, we are famously bad at transitions, but that was actually a great transition for us. We're sponsored by Panacea Financial, a nationwide digital bank built for doctors by doctors. So whether you're a fourth-year medical student, a resident, or an attending physician, Panacea is designed specifically for you. Panacea Financial offers free checking with no ATM fees nationwide, 24/7 customer service and loan options, custom made for physicians or trainees at every stage of their career. So instead of running up credit card debt, try their PRN personal loan. It's a better way to cover expenses like relocation, board exams, home renovations, or even consolidating high-interest debt. Their PRN personal loan is funded in as little as 24 hours, and interest rates start at half that of a typical credit card. They also support doctors in other ways, including helping them start, expand, or buy into a practice. So if you're ready to join the thousands of doctors who have declared independence from traditional banks, visit panaceafinancial.com today to open your free account. That's panaceafinancial.com. Panacea Financial is a division of Premise, member FDIC. Adam, why don't you start us off with a case to make sure, we're going to run out of time because we have a million questions about this topic, but why don't you start us off with a case and ask the first question?
Sure. Well, let's start on the wards at Kashlak. We're taking care of a 76-year-old man who has diabetes, coronary disease, who carries a diagnosis of mild cognitive impairment. And he came in a few days ago, was admitted for community-acquired pneumonia, spent a couple days in the ICU, and just transitioned down to the floor. And his partner mentions that despite improving, he just doesn't quite seem back like himself yet. So before we jump into this, obviously we're going to be talking about delirium tonight. Esther, do you mind just defining delirium for the audience and telling us how you think about this broad topic?
Sure. So I would define delirium as an acute disorder of attention and cognition. Some people might call it altered mental status, acute confusional state, encephalopathy, and so on. And it can also be very confusing to detect, I think, when patients have cognitive impairment or dementia.
Yeah, I think the coders like us to call it encephalopathy, but I feel like delirium it's just one of those terms that gets thrown around. But encephalopathy, do you think it's important to differentiate any of those other things that they may ask us to put in the chart when someone actually has delirium?
Yes. So one of the introductions, that thing that I didn't really mention, is that I am the president of the American Delirium Society. So I would like everybody to call delirium as delirium, but there is a difference. So delirium, as I mentioned to you, is a confusional state, changing cognition. Encephalopathy actually, would include delirium, but also comatose patients. And obviously, you can't assess for delirium in patients who are comatose. It's a little bit different. We do know that actually the reason why the coders ask you to change the diagnosis is because it does actually have a little bit of higher reimbursement rate, I believe, and that's the reason.
That makes a lot of sense, Paul.
Terrific. Well, good. We're keeping the lights on.
Yeah.
So we mentioned that we're getting history from the patient's partner who says the patient doesn't seem quite like himself. I guess I think seeing patients who have delirium in the hospital is often very sort of alarming to patients' family members. I'm wondering, as you're beginning the discussion with them, how do you have this conversation with the family member when you're sort of describing what's going on with the patient and trying to tell them what delirium actually is?
Yeah, so I would say that it's obviously very, very distressing for the patients, and patients themselves, which I can talk about in a bit, but also for the family members. For care partners, family members, we would say that if your loved ones become delirious, it means that they really can't think very clearly. They can't pay attention. That's really key. And is really not aware of their environment or surroundings.
You mentioned that it's different than dementia. And I know this comes up a lot. So can you just kind of pull apart those two ideas and kind of how you tell the difference between the two?
Yeah. So I'm actually a memory clinic specialist. So I'm an internist, geriatrician, but most of my clinical responsibilities on outpatient basis are at the Johns Hopkins Memory and Alzheimer's Treatment Center. So I think the best way to kind of think about is delirium, once again, is acute change in mental status. And dementia, I would say is more chronic. So this is where I think the family involvement, care partner, informants, all those things, people become very, very important. So especially, I think if you're working in the hospital, when a patient's admitted to the hospital, it's very difficult to determine if the mental status change is acute or chronic. And so you need to ask the family members, is this your family member? Is this your loved one? And actually, there's an initiative called This Is Not My Mom in Canada. So this is to bring attention to the fact that we sometimes miss delirium diagnosis because we may attribute it to the confusion to dementia. And so the providers need to ask the family members, is this a change from baseline? And so even if you have a patient who has dementia, the family member would say, yeah, my mom has dementia, but this is not my mom. And that is to make you understand that you should be paying more attention, that this could be not just chronic dementia syndrome, but also there could be an acute mental status change or delirium. And I would say another really important distinguishing point is attention. So when I see patients in my memory clinic, often even in fairly advanced cases of dementia, what they're saying to you may not make a lot of sense, but while they're saying it, they're very, very attentive to you. So attention is key. So patients who have delirium are very, very inattentive. So when you're talking to them, they might either kind of drift off, as in they're becoming inattentive, or even sometimes fall asleep. And so that should also kind of trigger your, higher suspicion for delirium as well.
Yeah, I find that when a patient's admitted to the hospital overnight and you're seeing them as the attending the next day, that's often the biggest question. And often by the time you're rounding, you might not know yet. And you're saying, what is this person's baseline? Are they always just barely able to tell you their name, or is this a brand new thing? And sometimes it's hard to know. And sometimes the only people that can provide that is the facility where that person came from, or I think also sometimes the family hasn't seen them in a while, and it's hard to figure it out just by talking to the family. So it is a challenging thing for sure. So I empathize. I'm sure other people are thinking the same thing. Well, Adam, do you want to move on in the case a little bit?
So you evaluate the patient. The vital signs are stable. He's alert and oriented to person and time, but frequently falls asleep during your interview. His lung exam's improving and his labs are stable. You're considering transitioning him to oral antibiotics in preparation for discharge, but are concerned that he may be experiencing delirium. So how can we confirm the diagnosis of delirium in a patient like this?
Yeah, so there are many tools that you can use, but I would say take-home message is that ultimately you're the clinician, and so we can have different tools to screen for delirium, but you would need to make the ultimate decision. It's like saying, can I just use MMSE to diagnose dementia? And the answer is no. So some of the tools that are available are called Confusion Assessment Method, or CAM, or 4AT. And actually, you can find both of them and just the forms and PDFs on American Delirium Society website. There's actually an app that you can download if you have an iPhone. It's called UB-CAM, CAM. It's very self-explanatory tool. And so, it's important to understand that there's a very helpful tools, but, once again, ultimately you make the decision. And I think all of these tools have thresholds. So I think it's kind of, it's like any other medicine, question. So we talk about delirium, but, researchers kind of talk about what we call subsyndromal delirium, as in delirium that might be brewing, that these tools may not pick up. So it's like saying, would you say 99 in heart rate is not an elevated heart rate, but it's 100 that's elevated? So we had to kind of get the, cutoff value. But if you suspect that a patient has delirium, even if the screening tool is negative, I think you should start a workup.
That reminds me, do you subscribe to the fact that delirium is an emergency, or a type of emergency? I mean, I've heard geriatricians say that before, that if you have a patient and they're having delirium, and maybe they were talking I guess inpatient setting or outpatient setting, it certainly you should pay attention to it. But how do you think about that, the urgency of delirium?
Yeah, I mean, it depends. So in the history, you might come up with, some cases where patients' family members kind of, when you, probe into it, they have kind of an ongoing low-grade delirium. Sometimes it comes and goes. I think the urgency is different depending on who they are. I would love to talk a little bit later about, not just really thinking about delirium as delirium, no delirium in a very yes or no dichotomous way, but really talking about delirium severity and duration and how those things are actually more important. If I may, Adam, just kind of go back to the delirium screening. So, I talk about, UB-CAM, CAM, 4AT, all those kind of tools. But, when you're rounding on a lot of patients every day, sometimes it's not easy to kind of whip out those tools and say, let me do a formal delirium assessment, among 134 things that I have to do today. So there's a quick bedside thing that I do, which really ends up being the ultra brief CAM, which is they have kind of distilled it down to two questions. One is, what is today? And then can you recite months of the year backwards, starting with December? So really that the latter one is testing for attention. And I find that, pretty much all of my patients are fairly receptive to at least getting started. They may not be able to complete it, but I rarely get complaints. I highly would discourage you from doing any kind of math-related attention test, like subtract 7 from 100. That pretty much is the quickest way to get kicked out of the room. So.
That's great. So the UB-CAM, because I was going to ask you, how long do these tests take to administer? The CAM, I haven't administered the CAM test or the 4AT test. Are those a 5-minute investment of time, a 10-minute investment, or?
I would say they're very, very brief, especially if you do something like UB-CAM and you have an app, it's probably 2 or 3 minutes. But once again, one thing that I want to kind of talk about is, since I do a lot of research in delirium, a lot of researchers work on creating briefer and briefer, delirium screening tools, hoping that more people will do delirium screening. That is not the barrier. We could have a 1-minute delirium screening tool, but it has to be something that actually makes a difference. So, we often ask our nursing staff to do delirium screening, and we often find that, they don't do it. And if you kind of think about it, what happens, if a nurse calls and says, it's usually intern on the other line. It might say, oh, doctor, your patient, so-and-so is delirium positive. You might say, thank you, and hang up the phone because, well, what do we do, right? What do I do with that information? And so you can imagine, no matter how brief the test is or screening test is, after a while, if the nursing staff feels that the information they're gathering is not really translating to action or something that is really done by providers, I think they would stop doing. So, I'm talking about, brief screening tools that you can do, the nursing staff can do, a lot of people can do, but, would also love to talk a little bit later about, what are some of the things that you can do once somebody is delirium positive.
I think before we get to interventions, just a question that came to me, and this may be the same way of asking just about risk factors, but are there any prediction tools? Are there ways to kind of anticipate who actually may develop delirium during a hospitalization? Yes,
there are a lot of delirium prediction tools, but I would say probably, the way I kind of picture this is, and I apologize, I am a memory clinic doctor, so I tend to be brain centric. So at the center of it is a vulnerable brain. And I would say, if you ask me, well, who would be at risk for delirium? I would say everybody. We actually see this in PICU as well, so pediatric population. So in older adults, it's the vulnerable brain in the center. So patients who might have recognized and unrecognized dementia or some type of neurodegenerative disease. And in those cases, it really doesn't take much, to push somebody over the edge and, they develop delirium. But we do see healthy younger people develop delirium, especially like at, say, an intensive care unit. Maybe somebody comes in with a car accident, 30-year-old, they're under a lot of sedation, so on. They might be on a ventilator. So the point is that they have a healthy brain, but the insult's great. So it's kind of a balance of what is the, kind of the underlying vulnerability of the brain, and how much insult is there, so that kind of balances it out. So I would say everybody is at high risk, but definitely older adults who tend to have underlying neurodegenerative process are probably at the highest risk.
Yeah, that makes sense. You mentioned earlier about using some of these tools as screening, and I want to ask a little bit about the utility of looking for this in all comers who are on your service, or certain populations who you might think are at risk, versus waiting until the family member said, "This is not my mom," to try to evaluate for it. So is there utility in doing this as a screening intervention for patients, even if you're not highly suspicious for delirium?
Yeah, I think there's, probably a two-part answer. So everybody's kind of looking to figure out who would be at the highest risk. How can we basically stratify? I can tell you that a lot of people are working on, like artificial intelligence, looking at big data, EMR data, to see when the patient arrives in the emergency department, are there some kind of algorithms or, risk factors that they can, basically immediately create to see this person, although they don't have delirium at this point, would be at high risk and so on. Now, but having said that, I want to talk about what's called, a lot of unrecognized either dementia or underlying neurodegenerative disease in older adults. So I did a lot of study in hip fracture population. If you look at hip fracture population, postoperative delirium is around 30 to 40%, depending on which study you look at. They tend to be older, mid-80s. And what we found out from what we call biomarker studies, so we looked at actually cerebrospinal fluid for Alzheimer's disease biomarkers, is even in very well characterized normal older adults, they had basically positive biomarker levels that will basically be equivalent to having Alzheimer's disease. So what that means is that just from like a dementia perspective, when you're diagnosing somebody with, let's say, Alzheimer's disease, just hypothetically, that disease process usually occurs even 20 to 30 years before it becomes clinically, manifest, so to speak. So you could have someone who comes into your hospital who is an older adult, is completely functioning at home, is normal, described as normal at home, could have full of disease in their brain, and all it takes is just a infection or disorientation being in the hospital to unmask, so to speak, that underlying neurodegenerative process, and you have delirium at hand.
Adam, I'm sure you've seen this before. I think I've had patients, family members kind of lamenting, they were fine, they were home, they were doing okay. Then they come in, they're pretty sick, and they have delirium, and it's like a really protracted, severe case of delirium, which, and then I always find those are the challenging ones to deal with. I'm not sure, Adam, if it's cases like that there, why you wanted to produce this episode, but
those are definitely, I think leading up to this episode, I realized how cavalier I can be sometimes with the subtle mental changes that happen with a lot of the patients that we take care of in the hospital. But those are the cases, the really difficult ones that obviously stick in your memory. Can I push a little bit more, Esther, and just ask, should we, I'm still a little bit curious about how much we should go looking for delirium. I know we'll get to some of the treatments and some of the treatment pitfalls in a little bit, but I'm curious whether this is worth really trying to search high and low for in our patients, or whether we should wait until there's something that really trips the wire for us.
Yeah, thank you, Adam. So, I think this also goes back to Matt's question about, is this an urgent issue? Is this an emergency? Why? I think, where the question is, why does it matter? Why is it important? So, I would say even like 20, 30 years ago, delirium was just thought to be some transient condition. It just happens in older adults. You didn't really need to about it because it just happened for a couple of days and it went away. Now we know better. There's a really bad long-term outcomes that are associated with delirium. Before I just kind of tell you about some numbers, I want to tell you about what I think is really important, which is patient's experience, patient distress. So it could range from, just kind of some dreamlike state to, in some cases, especially this has been true where COVID-19 has been described as a delirium factory. I think I remember reading an article in The Atlantic about this person who was in the intensive care unit due to COVID-19. And I think she had imagined that a nurse was coming over to basically saw her, arms and legs off. Incredibly distressing things that you can't even imagine. And so even though the patient looks like they're just sleeping and they're calm, and, we can talk about maybe hypoactive delirium a little bit later, the patient distress is very, very significant. If you're talking about older adults, we think that delirium occurs one older adult every 5 minutes. And it's associated with long-term outcomes such as disability, institutionalization. So you come in, to the hospital from your home, and now you have to be discharged to basically a skilled nursing facility. We know that it's associated with functional decline, higher mortality. But what we're really, really noticing now, and it's an important really focus, is that actually it's associated with incident dementia. And there are a couple of things that we have very good evidence that what's happening with delirium, and that delirium is not harmless. So, for example, especially in the perioperative settings, we have done biomarker studies. So people have shown that just blood tests of what's called NFL, it's called neurofilament light, and that's usually associated with like traumatic brain injury, dementia, and so on. And so what they find is that patients who have delirium actually have much significant higher level of change in that basically a marker of neurodegeneration, that when the patient looks like they're sleeping, there's actually neuronal damage that's occurring. Another important study that just came out, it's called Decide study, and it was done in UK. And what they did was that they basically piggybacked on a cohort study where older adults in the community were having baseline cognitive assessments every 2 to 3 years. Conveniently, those adults in the certain areas actually went to 2 hospitals. So every time they were hospitalized, the investigator she was able to actually do delirium screening on a daily basis up until discharge. And what they found, because they had a clear baseline neuropsychological testing result, is that when you came out, compared to those who had not experienced delirium, if you had delirium inpatient, you had 8-fold higher odds of developing dementia after discharge. And that was even higher if you had more severe delirium, if your duration of delirium is longer. So those are things that are just really coming out in the literature recently to kind of demonstrate definitively that, delirium is not something that we should ignore.
Yeah, because I've always seemed to observe the fact that sometimes patients get delirium and it's almost like they never rebound completely back up to baseline. And it sounds like maybe this research is confirming that.
Yep.
Well, thank you for frightening us. Can I ask you to disabuse me of a thought that sometimes pops into my head about delirium, where sometimes I think of it like, an elevated troponin in someone with subclinical coronary disease that gets sepsis, where there's some problem that exists, there's some issue neurologically or some cognitive impairment, and then something happens and it just kind of unmasks this already present subclinical thing. It sounds like what you're saying is that's not the case, that this is its own insult that kind of can drive things moving forward. But I'm curious what your thoughts are about that.
Yeah, I think it's hard to tease out. So we know that when somebody's experiencing delirium, there's neuronal damage. We also know that there's actually active inflammation going on. Same thing. Some studies that have done lots of different inflammatory markers, but I'm sure you're familiar with CRP. A lot of cardiologists get them. So basically, an inflammatory biomarker. Same thing where patients who have delirium or experience delirium have higher difference or change, once you've developed delirium compared to baseline. So I think that's kind of like currently, as far as we know, it's like a unifying theory of delirium is that a lot of this, these different, factors, one of the things that happens is that there's a brain inflammation. So let's say somebody's, having bacteremia or sepsis. There's a lot of like inflammatory mediators that travel through the bloodstream. We think, well, there's a blood-brain barrier, so that should be blocking it off. In older adults, a lot of those things are damaged, so that actually goes into the brain. Sometimes it activates, microglia, so which in turn, produces more inflammatory factors. And so the idea is that those things are actually damaging the neurons. And then if that continues for a long time, that can actually result in neuronal death. So that's the kind of the hypothesis. But I want to just kind of be careful, because often I tend to kind of think through this way too, is that, we're talking about delirium like it's a disease, but please remember that it's a syndrome. It's really important that when we're talking about, what's causing delirium and how do we treat it, we just have to think what did cause delirium. Was it, infection? Was it metabolic disturbance? Was it medication? So it's not a disease. And when we're thinking about prevention, treatment, and all those things, I think that has to be in the really the forefront of our thinking.
I want to bring it to the case. So we have this 76-year-old admitted to the hospital, mild cognitive impairment at baseline, and he's here with pneumonia. And now we're thinking we were going to discharge him, but he has inattention and he's falling asleep. We're trying to talk to him. One of the questions is, like, could we have prevented this somehow? You mentioned prevention. We're going to talk about how we might treat him. What can we do to prevent delirium? And yeah, let's just leave it at that.
Sure. I think it's important for everybody to understand that about 30 to 40% of delirium may be preventable. We can't prevent all delirium. And unfortunately, what's happening nowadays, I think in a lot of health systems, is there's due to staff shortage and a lot of other issues, I think a lot of patients end up boarding in the emergency department a little longer than they should. And so by the time you see them on the floor, they've been there actually, physically for, perhaps even 2 days, and they're delirious. So maybe the intervention in terms of prevention really should be, discussed even like in the emergency department setting. But when we talk about prevention, I want us to kind of get away from like envisioning like a pill. Because there is no pill that's going to prevent it. It's, what we call multi-component, non-pharmacological prevention that has been shown over and over again to be helpful. And so I just want to kind of take you through what that might actually constitute.
Sure.
So once again, it's kind of multi-component. So the first is like orientation activities. It could be as simple as just updating the board with the doctor's name, the nurse's name, the date, having the correct date to orient the patient, providing activities. Obviously, there's staff shortage. Why not bring the family in? Perhaps they may be able to engage the patient in conversation, continue to orient them. Fluid repletion is a big problem. We always think of fluid repletion as like just hanging an IV bag, and then the patient goes into CHF, and then we have to give them Lasix. So when I talk about fluid repletion, we're really talking about oral hydration. And then, of course, that is very, very person intensive, right? And how often have you gone on wards and seen your patient with a big, big gulp, 7-Eleven size, glass water, and, they're instructed to drink all of it by next shift, right? But it's out of the reach. So there's no way they could ever reach and, drink that. So there's a lot of barriers. And several things I want to say about fluid repletion, or for that matter, any of the components about prevention, is that take-home message today is that delirium is everyone's responsibility. and we all have to be in it. So, if the patient says, I'm thirsty, or I'm, hungry, or I'm, like, can you help me? It's not, why don't you, ring the nurse's bell? Or like, I'll ask the nurse to give it to you. We need to do it now. Like, there's no reason why we cannot help our patients take a sip of water, right? And if everybody does it, they will be fully hydrated. Especially with patients with dementia, if you give them a large glass of water, it's incredibly daunting. So what we actually recommend both home and hospital is actually, like a shot glass, like from like Niagara Falls.
Give them a flight of waters, right?
Yeah.
Like,
Just small. I don't know about flight of water.
Well, yeah, one of those wooden trays, like they give you the shots
Tap
at
water,
a restaurant.
Distilled water, Perrier. No, but in all seriousness, but thank you for that suggestion. So I did not think about flight or water, but like, small. And then you ask them to drink, and that's like manageable. And, they might forget it a little bit later. And so you come back and say, hey, would you like a little bit more water? So that's how we basically keep on hydrating patients. Early mobilization. So we want to talk about safe mobility, activating our patients. And that's often, unfortunately, kind of at odds sometimes with falls prevention. We're so scared of our patients falling in the hospital that we tethered them to the bed. And that is the fastest way to becoming disabled, encouraging debility and delirium as well. Feeding assistance goes without saying. Vision and hearing. So this is really important. Patients don't like to bring their glasses and hearing aids to the hospital because we always manage to lose them. But if they still have them, if they haven't lost it from last hospitalization, you can ask the family members to bringing them in. And also what I would say is that, so we use like pocket talkers sometimes for those listeners who don't know what a pocket talker is. And if you're old enough to know what a Walkman is, so it is a headset, and like you can talk to a microphone, and that basically amplifies sound. Now, one thing that's really important to understand is that communication is not just about amplification. So when you're communicating with the patient, if you just have mild hearing loss, you can actually change the way you communicate with the patients for them to hear more clearly, because hearing aids actually does not make your sound more clear. It's your enunciation. So getting their attention first. A lot of older adults have high-pitch loss, so you can lower your voice and talk like this, and they can hear you much better. They have hard time listening to SH and CH sounds because it's very soft. So if they look at you like they didn't understand the first time, the thing not to do is to say it out loud, the same thing over again. You have to rephrase and redirect them. Sleep enhancement, really inexpensive items like basically earplugs, and like not like talking loud outside of the room. Obviously, infection prevention, pain management. Too much pain medication or too little pain medication can cause delirium. Hypoxia protocol makes sure that making sure that they're well oxygenated. And finally, reducing psychoactive medication. So you can see it's a bundle. So somehow we need to figure out a way it's part of the workflow, and it's not a extra work that needs to be done by somebody else, because that somebody else does not exist.
How important is the sleep component? Because it seems intuitively, it seems like it's critically important. There has been a much needed push towards like not waking patients up for vital signs or for labs. Like, how important is sleep regulation? You did touch on it a little bit, but I feel like to me, just because I value sleep so much personally, I feel like it has to be critically important as part of the prevention too. Am I misguided there?
No, you are not misguided, Paul. You are right on the money. It's incredibly important. And so I think, the thing that I want to emphasize is we just talked about non-pharmacological methods, low-hanging fruit, but invariably our patients have, sleep disturbance because some of it is actually a lot of it is probably iatrogenic. We cause it for various reasons. And then we are either giving them, medications to make them sleep, which, could cause delirium, as well as, kind of more of even if they're not delirious, sort of a cognitive impairment the following day. We know that about, sleeping agents. I do want to say, one thing about, because we do give melatonin a lot for sleep, obviously it's not going to make them fall asleep. It's just to really, regulate the circadian rhythm. If you just close your eyes, your brain naturally secretes melatonin. So if you darken your room and like if the patients are not on the phone or iPad, or if the lights are not on, it will actually secrete melatonin naturally. So there are a lot of things that we can do environmentally to just kind of promote sleep, which is an integral part of delirium prevention.
I love all this, Esther. Sometimes in our notes, we just paste all of those topics, and I'm not sure how many of those strategies get implemented. Specifically, as I walk around and see the wrong date on all the boards, I think that maybe we're missing something here. So I'm curious if you have any recommendations for more of a quality improvement or systems science way to try to make this happen in our hospitals.
And let's we did have one suggestion come out of this: those wooden flights, to put the mini shot glasses with water. Guaranteed.
And everyone speaks with a very low voice.
Matt, I would say that's your IP, and you need to patent it right away.
Okay.
So thank you. So, I gave this lecture to, a group of learners, not too long ago. And the question came up, is there something like an order set or a delirium bundle, as, this person called it, that we can just order? That would make, our lives much easier. What I didn't ask this person is, well, who would do that, right? So we're talking about multi-component non-pharmacological intervention that I just described. And one of the tenets that I have is that we cannot give one more thing for nurses to do.
Yes.
We just cannot do that. And so we really have to be more inventive, creative. But I think also having visited lots of different hospitals and how people are practicing, one thing that I realize is that it's not whether you have a delirium bundle or whatever EMR system you have, it's the people and it's the culture. The places, units, wards where they have kind of a critical mass of people who are invested, of all ranks and different specialties, they make it happen. Like, so I visited one place where they said, Restraints, we don't do that. We just don't do that. We would just get patient safety attendants. We also call them sitters. To kind of sit with the patient. And someone who was there said that was a very different culture from a different place that this person had come from, where once the patient came into the unit, they automatically got like mittens, because that's what you do. So it's a lot of it is culture, because we know the evidence. So I think, when we talk about QI projects or how do we implement it, like we ourselves really need to be the change agent, and we need to basically talk to other people, get them invested. And, it really has to, stem from cultural change. We know what to do, but really changing culture of a hospital or unit is a really, really difficult thing. So it's not about creating a bundle or no bundle. It's about given what we have, how do we make it happen, and how much are we invested, in light of the fact that there's a lot of other initiatives that's ongoing at the same time, at any given time, and any given ward.
Yes.
I think we should get to wrapping up this case. So this comes up a lot, and I love the way, Adam, that you frame this, where you're like, well, we're ready to discharge him. Esther, how do we handle this when a patient's like stable delirium? Let's say they have had the same kind of delirium for 5 or 6 days. Maybe they're not requiring a 1-to-1, but they're not quite at their baseline, and they have they just kind of protracted hypoactive delirium, maybe mild severity. I mean, can we discharge patients in that condition? Would they get better maybe if they go back to familiar settings?
Yeah. So, Matt, if I may just kind of talk a little bit about hypoactive delirium for the listeners. So, often we think of delirium as, we envision patients who are like pulling out their IVs and so agitated. That's the hyperactive delirium. But that's really only about like 1/4 or 25% of patients. the more really common type is hypoactive. I call it the quiet delirium. And that's about 75 to 3/4 of patients. And so what they would look like, unless you active screening, is that they just look like they're sleeping or resting, and you have no idea that they're actually delirious. So these types of patients, I have to say, it's really also difficult for me as well, because I know as a geriatrician and dementia specialist that in some patients, delirium would take a long time to resolve. So a couple of things. One is if you are confident that you've worked up everything, all the etiologies, and you've done your best in terms of making sure that you've removed all the perhaps offending agents, their infections under control, all those things, and so you're now wondering, well, should I send them to a rehab place or should they go home? I think it depends. So if they don't really have anybody, they don't have they can't get a close follow up, perhaps rehab, is the best. But, sometimes, home is not a bad idea because, some of the things that I talk about with, my medical students is, well, even if the patient qualifies for, 3 hours of rehab a day, so acute rehab, what do they do for 21 hours? They have to lay in bed, right? And then if you try to get out of bed, you're asked to go back to bed. So when you're at home, even though you might not have nursing staff right by you, actually the patient's actually forced in a way to do more for themselves. Hopefully there's obviously family supervision. And so if you have a case where a patient has good support at home care nursing can do a close follow-up, or PCP can see them, really soon, a more familiar environment where they will be doing a little bit more for themselves might not be a bad idea.
All right. That's helpful. I know we could talk a lot more about that, but I know a lot of people are going to want to hear about a case of hyperactive delirium. Let's say we kept this patient an extra couple days and they got better. We actually were able to just send him home. So that guy did okay. But Adam, tell us about another patient.
So the next day we admit a patient who's 92-year-old woman with mild cognitive impairment from vascular disease who comes in after a fall and a hip fracture. She's now post-operative day 2, and the nurses call you for increasing agitation and aggressive behaviors. They are worried. They say that she's going to try to get out of bed by herself and have a fall. So this is obviously a very different type of patient from the first one. So can you just talk us about how you would approach this situation?
Sure. So once again, I want listeners to kind of think, well, delirium is not a disease, it's a syndrome. So I still need to figure out what's happening. So especially in an agitated, hyperactive case, you just want to kind of resolve it over the phone. But I think you really need to spend some time figuring out what is causing the problem. I'll give you an example. There are a lot of, especially male patients who get up frequently during the night. They do that at home because they might have BPH, right? But if they do that in the hospital, they might be labeled as being, wanting to get out of bed all the time, being agitated. It's something that we have to do something about, and maybe perhaps even with the medication. Maybe we can go and ask the family members, okay, do you just need to go to the bathroom? And maybe what we need to do is assist them. If you think about, also agitated case, do they have like congestive heart failure? Maybe they're like volume overloaded. Could they have had PE? I've seen cases like this where it's just manifesting as agitation. Mm-hmm. We do need to pay attention. We need to figure out what's going on. So the point is that we still, once again, just as, we did for hypoactive delirium, we need to figure out what is causing the hyperactive delirium. So I think that will be like the first step. I'll be happy to also talk about, if need be, pharmacological treatment as well. I think that's something that the listeners might be very interested in.
Adam, does that ever come up on your service?
This is a completely foreign thing.
I'm sure you've never seen a case like this.
I always find these situations really, really challenging because, especially if a patient does have hyperactive delirium and we've come to that conclusion. Sometimes they're younger patients. Sometimes they're, more physically, it sounds like, capable than maybe this 92-year-old woman after a hip fracture. But a lot of times the question is, how do we keep this patient safe? How do we keep our nursing staff safe? I've had patients swing at me only some of the times has it been deserved. But how do we kind of keep all the staff that are trying to do our best to take care of these patients safe while also not, worsening the patient's condition? So I'm curious about your thoughts in this scenario, which I'm sure you've dealt with many times too.
Yeah. So I have to say that most often, the first thing that I try to do is see if there's a staff member, so patient safety attendant who can be with the patient and just kind of reorient them. And often, that kind of works well. So because I think especially if somebody has cognitive impairment, they have a lot of difficulty expressing what it is that exactly, they want. And then kind of it escalates from there due to the communication problems. If you have like one-on-one attendant, it works a little bit better. We do not recommend antipsychotic use for prevention or treatment of delirium, but I do want to tell you that if patients' safety or staff member safety is in question, as in like they could harm someone, I think medication use is indicated. So evidence is not there. So for first generation and second generation antipsychotics, which are mostly antidopaminergic agents, if you look at really well done, high quality randomized control trials, they don't reduce delirium severity. It doesn't shorten delirium duration. It doesn't shorten length of stay of hospitalization, and so on. So it doesn't really, work. So sometimes we think, well, maybe what it does is it just kind of sedates the patient, and that's how it works. And we've actually looked at sedation as one of the side effect profiles, and there's no difference between medication and placebo. So it's not even that. So that's, that's the evidence. However, I am very much empathetic to the fact that, there are cases when it's very difficult and something needs to be done. So I want the listeners to kind of think about, what we have at hand. I rarely use, first generation like haloperidol. So when we're talking about like second generation, we're really talking about like quetiapine, olanzapine, and risperidol. So I always kind of think of them as like a different side effect profile. So from weakest to strongest antidopaminergic activity, so that's where the side effect comes from, is Seroquel, and the one step stronger is olanzapine, and then one step stronger is risperidol. And then, so there's a side effect profile that I kind of consider. And then I think about the formulation. So for example, one of the complaints that, I get is, oh, you prescribed the pill, but they just, basically they'll just spit it out. So it's not going to work. Can you give me an IM, order? I've never given an IM order. So one thing that you can do is olanzapine comes in disintegrating tablet. So actually you can just kind of pop it in their mouth and it would just like dissolve. But it comes in 5 milligrams. So the idea is that for whatever you're using, you want to use the less side effect one with the lower dose and lower frequency. And so you could even get the 2.5 tablet and maybe cut it in half and basically, mix it with something. Risperidol comes in liquid formulation, 1 milligram per milliliter. So that can also just be given really more easily. It's and they can't really spit it out. So I think about all these things and formulations that can be easily absorbed before really thinking about something like IM. So that's kind of those kind of things that I do. So the take-home message is that if you're talking about evidence, it doesn't exist, but we do fully understand that there are instances where we do need pharmacological intervention. And so these are some of the things that you can think of when you are at that step.
And if there's actual psychosis, hallucinations, do you consider that an actual indication then for the antipsychotics, if they're having that as part of their delirium? Or
well, so it depends. I think, so once again, I see a lot of these hallucinations, psychosis in the context of dementia patients.
Yeah.
So you kind of want to kind of probe into, well, what is the nature of it? What is it? And is it so there are patients who might have some, ideas, but it's not really distressing. And for some people, they actually feel like somebody's trying to harm them. And so there's like an actual distress. And so I think depending on what the nature of those things are, that's when you make the decision of, does this thing, need pharmacotherapy or not? Or just something, that you can calm down by soothing them and talking to them.
So you had mentioned using restraints, Dr. O. So when would you consider doing that, or what are the kind of scenarios when that might be appropriate? And I'm assuming that almost all the time, that's something you try to avoid incredibly.
I really want to once again emphasize that I really think it's a kind of a cultural thing. As in like what the unit or ward is doing. I had not seen restraints in many, many, many years. And I saw, it happen once, and I was kind of very surprised. And once again, I had been visiting different hospitals, just really trying to figure out, how, people practice differently. And once again, it really depended on, what the culture of the unit or ward is, whether restraints are used or not. But I can see how, like, let's say an ICU setting, if the patient is, obviously trying to extubate or, or something like that, perhaps that's indicated. But I'm not an intensivist, so I'm not sure that, so I don't practice an ICU setting. So I'm not sure that's something that I can comment on. But I can say that, in addition to restraints, so that in itself can cause more delirium. I want to talk about other things like Foley, right? So that's it's not a restraint, but that's like something that kind of tethers them to like a place, a bed, or So that's something that. Especially, house staff, I think we need to have the numbers, I's and O's, and unless somebody's in acute congestive heart failure, I think we're perfectly capable of figuring out, whether somebody's volume overloaded or not, and we don't really need exact I's and O's. And if anything, prolonged use of, Foley, one can cause delirium, but of course, can cause, urinary tract infection, iatrogenic as well. So those are kind of, things that I think about. Restraints, Foleys, unnecessary lines, maintenance fluids that we forget about, right? So really important that we just kind of really pay attention to that on a daily basis.
We're coming to the end here. So any other burning questions? I have one or two more that I was going to get to, but anything else?
Yeah, sure, Matt. Before we kind of wrap up this section, I was curious, Esther, if you could tell us a little bit more specifically about approaches to the behavioral interactions to try to de-escalate these situations, whether there's anything that has specific evidence or whether you just have any kind of recommendations or things that you can refer the audience to be a bit more effective stewards of some of these behavioral approaches to trying to make the situation better.
Sure. So, and I would say this kind of comes from, once again, my work experience with patients who have cognitive impairment, and of course they come to see a lot of us at the memory clinic because of the behavioral problems associated with dementia. And I would say similar techniques also work in delirium, although obviously we're talking about more of an acute mental status change that's different from dementia. So one of the things that we need to do is redirecting the patient. So especially when patients have dementia, they have delirium, they might have fixed ideations or whatever it is. Once again, it's kind of we need to kind of probe into what is the nature of the delusions or hallucinations they have. But really, I'd like to just kind of change the topic. So if they kind of perseverate on one thing, I really just we try to redirect them by changing the topic. One of the biggest reasons why patients actually become agitated, especially on the outpatient settings, and somewhat true for inpatient settings, is because they don't have enough activities. Okay, so what I mean by that is they need to have activities, and it can be fairly variable. So in our hospital, we actually have a recreational therapist. So she actually comes and actually, works with individual patients, figure out what they like, and then just kind of occupies them. Sometimes, in more severe cases, it's like one-on-one activity. But she might, do some group activities that really occupies the attention of the patients, and they do much better, and the agitation, de-escalates. I also think environment is, very important. We often have a lot of noise around us. And so this is also true in outpatient like dementia case, where we actually think, I might like sometimes, grandparents who might have cognitive impairment, and we say, oh, wouldn't it be great if they, spend a lot of time with like little small children, their grandchildren. And what happens is a lot of noise, a lot of commotion that tends to really confuse them. And actually they get really agitated. So really keeping a calm environment, calm, soothing environment. I know some hospitals have like roommates, some are more private. So, also kind of depends on, what kind of environment they might have. But I really think one of the better ways also is somehow connecting the patients with their family members. So really at the height of the COVID pandemic, when no one was really allowed to come, so no family members, we've had patients who, I'm embarrassed to say, I kind of almost said, this patient really is not going to survive. And I had one intern who said, Dr. O, like, I'm going to look after this patient. And some of, aside from, obviously being really medically attentive, this was a very, very sick gentleman from COVID-19, I think in his 80s. He got an iPad, did FaceTime with his family. He got to see his wife. And I can tell you, he came to me from ICU with lots of tubes and just kind of everything. And all of those things kind of came out. And I know he went home. Like, I know that he went home. So like family interactions, that is just also very, very critical. If they can come and see the patients in person, that's wonderful. If not, just really making sure that we can get them connected and just paying attention to that, I think will go a long way of really reorienting them, and just hearing, basically families members' voice can also be very, very calming.
I think there was even one small trial using front-facing iPad video or some sort of screen so that they could see family members even if they weren't there. And there was at least one article I saw in the past couple of years about doing that.
Yeah, and also I saw in one of the daughters from one of my patients, she brought one of those screens where the photos kept on rotating.
Mm-hmm.
And I would see my patients just looking at that. It was a pretty large screen and just, smiling. And also, I think another thing is, talking about really humanization of, medicine is I've seen some recreational therapists who would ask the family members to kind of make a collage of the patient.
Mm-hmm.
And sometimes you have like pictures of, their current, them, patients, pictures very current, but when they're younger and all stages of life. And I really think people get really interested, tell me about, who you are, what you did. And that really makes them engaged as well. So I think just really getting to know that, creating an environment where the staff also want to get to know the patients and getting them engaged as well as family members, I think can go a long way.
I want to take a step back. It's been a couple of years since I've done inpatient medicine, thank God. So those days are far behind me. But I can say, I think especially with the hyperactive delirium, I sometimes see those patients get the $1 million workup. So we're doing your analysis, and God help us, we're checking a TSH, even though we would do exactly nothing with it, even if it was abnormal, or neuroimaging, or a troponin for some reason. But I guess the point being is I feel like there's sort of a fair amount of diagnostic workup that goes into just, I think, almost out of desperation sometimes. I'm wondering, in your experience, sort of what is warranted and what kind of things do we maybe not do as well as we could diagnostically when we're trying to sort of get to the bottom of hyperactive delirium?
Yeah, I guess the thing that I see most often is a TSH, vitamin B12, folic acid.
Sure, yes.
Which is kind of like a dementia workup, and that's fine. These are some things that we're all kind of taught to do. Basic. But I would do basic metabolic workup, like just getting a CMP, CBC. I do want to say, something about TSH. We do know that often hypothyroidism is looked for in dementia and delirium cases, and they're over-treated. There's some good evidence showing that actually, if you have dementia diagnosis you tend to get treated more for maybe borderline TSH than if you don't. There's some also studies that show that perhaps, use of, basically thyroid replacement therapy over time may not be, so good for you. But anyway, so that's, getting off track a little bit. So once again, Paul, just like you said, sometimes we can get a little bit, desperate. But I would say, other than that, just the regular workup, looking at medications, I think is, really, really critical. And sometimes we think we need all the medications, but once again, we might, but we could always use a lower dose. If it's a critical medicine, making sure that it's obviously renally adjusted. In terms of CTs and, EEGs, my yield with EEG has not been the best. It's always just kind of shows, slow wave. CT,
Right.
If the delirium goes for a long time, or obviously, if you're finding something focal, I think it's warranted. I think I've ordered LP, once or twice, but not that often. You obviously have to have other signs to, suspect like something like like meningitis or yeah.
And thank you for asking that, Paul, because that was a question that we talked about some of these like severe, protracted, especially for me in the hypoactive delirium, especially if the patient was functional more recently before they came in. I feel like those patients end up with MRI, EEG, LP, because you're just like, we didn't have enough. We were surprised that the person had this bad of a delirium, and they end up getting that bigger workup, in my experience. And I struggle what to tell the family members there. Like, will they ever get better? I don't know, because sometimes I've seen it go on for weeks and then, maybe they never bounce back. So I think those are the toughest cases. Any comments there? Otherwise, I wanted to ask you just one question about treatment pitfalls, but any comments or response to those? Anything you tell patients when you're in that situation with that like 3 weeks of delirium?
Yeah, that's really difficult. We do know from like hip fracture studies that actually when they come in for like a 30-day follow-up with an orthopedic surgeon, there's some of them are still delirious, and then some, still like 3 to 6 months as well. So those are very, very, very difficult. And I, as a memory clinic physician, actually see them on my end. Actually, that's how I got interested in delirium, is because I would have patients' family members bring the patient and say, my mom was normal. She was living independently across the street from me, and here she is. And she, has like moderate dementia. And at first, I have to say I was like in disbelief, like, oh, surely this must have been going on for much longer. But the more cases I saw, and there was no rhyme or reason, like there was like one procedure they went through or whatever that kind of, happened. But invariably, when I really probed into it, they would say, yeah, right after surgery, went a little bit longer than expected, but like they became really confused and we thought it was just like narcotics, but then it never went away. And here she is, or, here he is. So that's kind of how I got interested, is like, these new onset dementia that I was seeing in my memory clinic, and then their history of being in the hospital and, patients becoming delirious. It's, so we can think about, psychotropic medications, but I would say also, management of comorbidities is also important. Some people who have diabetes and their glucose is out of control, whether it's too low or too high. I pay it as an internist. That's how I approach my memory care, is like I pay attention to all of those comorbidities, and that should be true for prolonged delirium. But yeah, it's not easy. I'm not sure that I have like the magic solution to that.
Thank you. So last question before we get some take-home points is, what did you want to point out any big mistakes or pitfalls in treating delirium?
I guess it's usually kind of too much and maybe inappropriate antipsychotic use. So I fully recognize that when we talk about higher mortality, extrapyramidal symptoms of antipsychotics, those are usually associated with prolonged use. So we're not really talking about 1 to 2 days for delirium treatment. But when you look at the literature, what we find is that people who were for the first time prescribed antipsychotics, probably for something like ICU delirium, good about 20 to 30% actually end up having them at the time of hospital discharge. And it probably happens for several reasons. One is, feel like, well, if they also have another, agitation, episode, no rehab's going to take them. So, for preventive measures, we're just going to have them the medication, or how neglectful are we? Sometimes we just kind of copy, what they were on without really thinking, item by item or medication by medication, do they still need this? Or thinking that somebody on the other end, and I don't know who that would be, a primary care physician or somebody would know to take them off. And the thing is, the reality is that when you receive them on outpatient basis, and I think, Paul, this is something that we talked about outpatient is, well, like, I'm not really sure why this was started, but I'm sure it was for a good reason, and I probably need to keep it on. And so that is the danger, is this kind of in treatment is what was meant to be a short-term, low dose, low frequency ends up being a very prolonged use that actually ends up being very, very harmful.
That's such a great point, because it's especially something like an antipsychotic where you see it. I'm like, well, somebody put them on it for a reason. Like, you don't want to stop that one. And it was probably, God, for some confusion that happened months before they actually landed back in your office. That is chilling.
Along with the proton pump inhibitor for while they were intubated.
Sure.
Right. And now they have C. diff. But really, truth be told, just the side effects. So, we're talking about, well, it can cause stroke, it can cause, high mortality. But in fact, on day-to-day basis, they could have orthostatic hypotension, right? I mean, it could actually be causing them confusion, right? Actually, some things that we do when patients come in with really bad agitation in the hospital is we peel off their medications, and they actually do much better. Sometimes the brain gets completely overloaded with, psychotropic medications. So, in an effort to do, good for our patients, we end up doing harm. So I think, the less is better. I always tell my patients, the fewer doctors you have and the fewer medications you're taking, you'll live longer.
Did you have a final one or two take-home points that you wanted to leave the audience with? This has been, I think, just a really fantastic interview. I'd like to book you for at least 2 or 3 more hours at some point in the future.
Okay.
All right. But just for now, we have to leave the audience wanting more. Paul, I'm told in show business that's a good thing to do. Are we in also, Paul, are we in show business?
It's great questions both, Matt. We should probably start leaving the audiences wanting something.
Okay. Well, so I think I want to say that, some of the common diagnostic mistakes that, that we see is actually, not recognize delirium because we don't actively screen for delirium. So hypoactive delirium is missed, and it's the most common type of delirium. But you can't. Often you miss it because it's not in your face delirium. So I would say that's the most common pitfall. What's the most common mistake? Treatment mistake or workup mistake would be. I think, we can all it would resonate with all of us. Just checking the UA and not looking for anything else, or keep checking the UA until it becomes positive, right? So, yes, sometimes UTI can cause delirium. And here's a take-home message. Even if it is, what you need to do is look for another cause, because delirium is usually multifactorial. So if you have a borderline UTI and you say, well, this is it, and I'm just going to give them IV antibiotics, and, this is all going to get better, and you walk away, you're making a big mistake, because invariably something else is going on. Another thing that I would like to actually talk about in terms of treatment, just very briefly, is that, I work on the wards, 2 weeks at a time as a service attending, and, all my residents and interns do as well. And so sometimes, because I emphasize prevention, I just want to make the, listeners aware that when you come on the wards, if you're in service or you get a sign up from a colleague and you find your patients to be like already delirious, and to say, oh, well, I kind of missed the, window and it's all lost cause. I think one of the things that I tried to impress upon you today is that actually, no, you can do so much more for your patients. And I'm going to ask you not to walk away from your patient. I'm going to ask you to go back, look at that medication list again, make sure you didn't miss any infection. Just go over it again, because one of the things that we know from really evidence-based is that if you can actually reduce the severity of delirium, and actually you can reduce the duration of delirium, you can make a big difference in a person's life. And we'll probably never see them outpatient basis. And, but we know that will actually shorten the damage that happens in the brain. So just please, make sure that even if you find your patient to be already delirious, just help them. And I think, I think it'll just go a long way of just the patients doing well on a long-term basis.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Great. Kind of unsettling. Get your show notes at thecurbsiders.com, and while you're there, sign up for our mailing list to get our weekly show notes in your inbox. Plus, twice each month, you'll get our Curbsiders Digest recapping the latest practice-changing articles, guidelines, and news in internal medicine.
And we're committed to high-value, practice-changing knowledge. And to do that, we want your feedback, so please subscribe, rate, and review the show on Apple Podcasts or on Spotify. You can also email us at askcurbsiders@gmail.com. A reminder that this and most episodes are available for CME through VCU Health at curbsiders.vcuhealth.org. I wanted to give a special thanks to, Paul, what are we calling him? Hospitalist whiz kid, Dr. Adam Barelski.
I think, at last check, that's right.
For helping to write and produce this episode. Technical production for the show is done by the team at PodPaste. Elizabeth Proto runs our social media. Stuart Brigham composed our theme music. And Paul, with all that, until next time, I've been Dr. Matthew Frank Watto.
I've been Dr. Adam Barelski.
And as always, I remain Dr. Paul Nelson Williams. Thank you and goodbye.